Diabetes Connections is brought to you by the only ultra-rapid-acting inhaled insulin, by Omnipod 5, the only tubeless pump that integrates with Dexcom G6, and by Dexcom G7, powerful, simple diabetes management.
This is Diabetes Connections with Stacey Sims.
This week, the long-awaited Medtronic 780G is now FDA approved. It's been out for 2 years in Europe and has features that are a bit different from other commercially available systems in the US, including a target range down to 100.
And it's just been proven to do so successfully without really increasing a lot of time below range. You know, what will the next system lead us? Will it be below 100? I don't know, but it's so nice to be waking up with glucose levels that are so much closer to someone without type 1 diabetes with this lower target.
That's Heather Lackey, Global Medical Education Director for Medtronic. She also lives with type 1. We talk about what else this system can do. Remember, this is the one with the 7-day infusion set, and I ask a lot of your questions. This podcast is not intended as medical advice. If you have those kinds of questions, please contact your healthcare provider. Welcome to another week of the show. Always so glad to have you here. You know we aim to educate and inspire about diabetes with a focus on people who use insulin. I'm your host, Stacey Sims, and we are getting some big FDA approvals. Along with the Medtronic 780G, we got word that Beta Bionics iLet will soon be commercially available. As I am recording this, I do have an interview set up with the Beta Bionics CEO. If all goes to plan, that will be our show next week. Real quick, while the original iLet dual-chambered pump was not what was in front of the FDA, the pump that has been approved has some really interesting features. It's unique in that there are no steps to the programming. When you get your pump, you're not putting in basal rates or insulin sensitivity factors or anything like that. All you do is put your weight in. But that is for next week. You can follow me on social media. We've already shared some information about the iLet, and I've done many episodes in the past if you want to listen to those to get an idea of what was approved. But this week, we are talking about the Medtronic 780G. As you likely remember, Medtronic had the very first of what we now call AID systems, automated insulin delivery systems, with their MiniMed 670G, and that was approved in 2017. We've been hearing about the 780G for a long time. It was submitted in 2021. I've talked a lot about the delays in the news episodes. It has been approved in Canada since last year. It was approved in Europe in 2020. We're going to go through lots of features of the pump, but you should also know that the sensor used with this system, the Guardian 4, is approved with no finger sticks for dosing, which to me is one of the most significant changes. My guest to talk about all this is Heather Lackey. She has been with Medtronic for more than 19 years. She delivers medical education strategy for insulin pump systems. She trains Medtronic education teams around the world. She lives with type 1. She was diagnosed at age 16. She was also a consultant on the movie Purple Hearts. She also popped up in a scene in that movie, and yes, I asked her about that. Lots to get through, but first, Diabetes Connections is brought to you by Afrezza. Afrezza is the only FDA-approved mealtime insulin that comes in a powder you inhale through your lungs. So why should you consider this unique alternative to mealtime injections? Afrezza is another option if you want to lower your use of needles or if you're experiencing skin reactions at your injection sites. And it is ultra rapid acting, so you can take it right when your food arrives, even unexpectedly. Find out more, see if Afrezza is right for you. Go to diabetes-connections.com and click on the Afrezza logo. Afrezza can cause serious side effects, including sudden lung problems, low potassium, and is not for patients with chronic lung disease such as asthma or COPD, or for patients allergic to insulin. Tell your doctor if you ever smoked, have ever had kidney or liver problems, a history of lung cancer, or if you're pregnant or breastfeeding. Most common side effects are low blood sugar, cough, and sore throat. Severe low blood sugar can be fatal. Do not replace long-acting insulin with Afrezza. Afrezza is not for use to treat diabetic ketoacidosis. Please see full prescribing information, including boxed warning, medication guide, and instructions for use on Afrezza.com/safety. Heather, thank you so much for joining me. I have a lot of questions for you about the new system, but first, welcome. I'm glad to have you here.
Oh, thank you, Stacey. It's my pleasure to be here and so nice to get to meet you. I've listened to your podcast and just excited to be a part of this one.
Oh, well, I'm thrilled to have you. And I'm sure you don't mind if I say it has been a long time coming. Lots of people are very excited about this improvement. Can we start by just talking about the 780G? What makes this different from the Medtronic pumps that have come before?
Yeah, well, the MiniMed 780G system is different in the fact, of course, let's say what it still has, right? It still has automated basal insulin, and that insulin is based on the sensor glucose values. But this system is set apart because it delivers those auto correction boluses like every 5 minutes if needed. So we know that life with type 1 diabetes, as you well know, as a mom of someone with type 1 and me living with it, we know that life does not go as we expect all the time and as planned. And so many things affect our glucose outside of the three things that we've always tried to juggle for years, right? Food and insulin and exercise. But now that we really kind of identify that there's so many other things that are impacting our glucose, it really brings to light the fact that we don't get it right 100% of the time when we dose insulin, we adjust food. And so that's where those auto corrections that are coming in real time every 5 minutes if needed can really help. And what I love about this system is the auto corrections. You don't have to be sky high to get an auto correction. As a matter of fact, you don't even have to be high before they begin. They're really kind of thinking like a pancreas. And as soon as sensor glucose rises over 120 milligrams, if the basal is working as hard as it can and it's saying, hey, I need help, then the auto corrections come into play and they can start dosing a correction bolus every 5 minutes if needed.
So what is the difference between the auto basal and that bolus that you're talking about? Because, the automated systems that are out right now already adjust basal every 5 minutes. What is actually happening when you say, and it's also giving a bolus?
Yeah, so the bolus happens every 5 minutes on top of the basal, right, Stacey? So let's say, again, the goal for MiniMed 780G, there were kind of two goals in play, right? We wanted to further improve time and range, compared like with the MiniMed 670G system without compromising any safety, because we all know we can drive down glucose, right? But you don't want to have a lot of lows. And we wanted to reduce the daily interactions with the system. And those daily interactions, right, the alerts and the alarms and all of the safety pieces that were added to MiniMed 780G, those have all been now relaxed. And so less interaction and an improvement in time and range without sacrificing hypoglycemia. So what's nice about this system is you not only are delivering the auto basal, like you said, right? We have auto basal in other systems. But now, if the auto basal cannot keep the glucose level in the target range, it predicts that the glucose level is going to go higher than it would like, then that's when those auto corrections come. And they don't come once an hour. They come every 5 minutes. As soon as that sensor glucose rises over 120 milligrams per deciliter, if the system says, hey, I'm working as hard as I can with your basal, and I'm not able to keep your glucose at the target range that we want, right? And we'll talk about targets in here in just a minute, hopefully. But if we can't keep your glucose at that target range, then I'm going to ask for some help. And that's where those auto corrections, and those are boluses, right? Boluses that happen every 5 minutes without the patient having to agree to them or take any action on their part. They just happen automatically.
All right, I have a few more questions about that, but I'll get back to that in a couple of minutes because I feel like most people will just see the results and they may not have too many questions about exactly what's going on there. But I want to get back to that bolus in a minute, but you mentioned range, and the 780G has a lower range than Tandem and Omnipod 5 have currently, right? It's correcting down to 100, or that's a choice. You can adjust that.
Yeah, there's a couple of things that are different and new about this system. And MiniMed 780G definitely treats to a target, not a range. And you're right, though, the target is the lowest target at this moment that's available. And so the auto basal target, you can set 3 settings or 3 different targets are available to where the person with diabetes, their healthcare provider can really identify which target is best for them. But the 3 targets are 100 milligrams per deciliter, 110, and 120. Now, 100 comes as kind of the default autobasal target, and that's because we know that this system, with all of the copious data that we have and all of the simulations that were done before the system was even launched, was using that 100 target, and that's what the system is built around to be the best target to use.
We should note that Tide Pool Loop, which was approved by the FDA a few months ago, can correct down to 87, but it is not available in any insulin pump yet. It's a software program that was approved. So 100 from Medtronic is the lowest that you can actually use right now. But it's interesting that's 100, 110, and 120, where some other systems have, an exercise mode that is a higher range. Do you have any insight as to why those were chosen?
Well, those are the closest target to mirror a normal functioning, system, a system without diabetes. And the interesting thing is the 100 target is very much achievable without sacrificing time below range, right? So we're able to drive with the auto basal target being set at 100 and with having the auto corrections that are even delivering up to every 5 minutes if the system, determined that those were needed. We have the algorithm that built to drive the system to 100. And it's just been proven to do so successfully without really increasing a lot of time below range. What will the next system lead us? Will it be below 100? I don't know, but it's so nice to be waking up with glucose levels that are so much closer to someone without type 1 diabetes with this lower target.
Let's talk about the sensor, because there are changes here too, right? Tell me about the sensor that goes along with the 780G.
Yeah, well, the Guardian 4 sensor is the sensor that it works with the MiniMed 780G system. And the Guardian 4 sensor was designed really to reduce the burden of daily finger sticks. That was the whole goal. Let's remove calibrations from the system and let's try to develop a system that doesn't require finger sticks. As we know, sometimes finger sticks still are needed with any of the systems and sensors, but the majority of the time when our patients are in the SmartGuard feature is they are using the sensor glucose to bolus off of. There's no real need for a finger stick glucose. And interestingly enough, most patients spend upwards of 95% or so in that SmartGuard feature. And so many patients will tell me, I am forgetting my glucose meter at home. And I had one patient that went on a trip. He went out of the country and he said, look, I totally left insulin and glucose at home because I had kind of forgotten to take my meter bag with me.
Wow.
Learning lesson for sure.
Oh my gosh. Yeah, my son goes without a meter quite often since, we use the Dexcom and the Control IQ system from Tandem. But yeah, you don't want to forget your bag entirely. That's not good news.
Of course. Okay, if that's now a burden that is taken off of you, and that's lovely.
Yeah, no doubt.
Still need to be prepared, right?
Yeah, absolutely. And I think it's worth pointing out that this is the only automated insulin system in the United States that is one system, right? It's a glucose monitor, infusion set insulin pump that's all Medtronic. And this system has that extended infusion set, right? So you're talking a sensor you wear for 7 days and an infusion set for 7 days, right? We'll get right back to my conversation with Heather. But first, Diabetes Connections is brought to you by Omnipod. And when you're deciding on a brand of insulin pump, you got a lot to think about, especially if you've never used a pump before. It really can seem overwhelming. I remember that. There are a lot of choices, and you want to make the right decision. And that's why I'm so excited to tell you about Omnipod 5. Curious about trying an insulin pump or seeing what life without tubes is all about? Unlike traditional tubed pumps, you can try Omnipod without being locked into a 4-year contract. You might even be eligible for a free trial. Go to diabetes-connections.com and click on the Omnipod logo. For full safety risk information and free trial terms and conditions, also visit omnipod.com/diabetesconnections. Now back to Heather answering my question about this 7-day infusion set.
That's exactly right. One kind of new feature of the MiniMed 780G system is the extended infusion set. And that extended infusion set, it's been launched for a few months in a few different countries, but it comes now with the MiniMed 780G system and really allowing people to just kind of have to think about changing a sensor and changing their infusion set just one day out of the week versus anymore. And so that system, I have so many people that will go, Heather, you've told us for years, that we have to change our infusion set every 3 days. And why are we able to start to use a system now in this infusion set now for 7 days? And it's really simple to explain without getting into a lot of engineering details. But that infusion set is made with this advanced material. And what it does is it helps to reduce the insulin preservative, kind of the loss that we would typically have. It helps to maintain the insulin flow, and it helps to maintain the stability of the insulin. And so there's such a reduced risk of any kind of blockage or occlusions with your infusion set whenever you use this new extended infusion set. And I always have to remind patients and people with diabetes and their families, make sure you're only using the extended infusion set for 7 days and you're not using your current infusion set for that long because the materials are different.
Yeah, good point. Can you use any insulin in those extended infusion sets?
So, well, in the MiniMed 780G system, the insulins that are approved and on label are Humalog and Novolog. So both of those are available to use with that set.
So no Luja, Fiasp, just checking.
Those are not approved at this time.
Got it. I had a listener ask if the duration of insulin is adjustable. Is that a setting that people can kind of go in and tinker with?
Yeah. So active insulin kind of talks about is our duration of insulin kind of tuning knob that is in the programmable settings on the MiniMed 780G pump. The active insulin time is of the two settings that are critical, it's one of the two, right? The first setting is the auto-basal target, looking at that 100 glucose target for most people with diabetes, but then also setting the active insulin time to 2 hours. And a lot of people will say, look, I've never had active insulin or insulin on board. I've never thought that Humalog or Novolog was out of my body in just a couple of hours. And so it's interesting that Medtronic is recommending a 2-hour active insulin time. Why is that? And the real answer is this is what the algorithm was designed around, right? It was designed to have the ability to, the algorithm is asking the patient, if you set the active insulin time to 2 hours, then that gives me the ability to calculate insulin if I think it's needed. Right? That doesn't always mean that you're just going to get insulin stacked on top of, each other, a dose on top of a dose every 2 hours. It just means it gives the algorithm the ability to give corrections sooner. And whenever you're giving those auto corrections as frequently as every 5 minutes, it makes sense to be able to just kind of give the algorithm the freedom to make the decision if it's needed. And anytime I have someone that really wants to debate this, and understand how the algorithm works, I just always have to say, let's just look at the data. We're not stacking, we're not having hypoglycemia in the tens of thousands of patients that we have data on.
Yeah, it's actually, I wish I had a diabetes educator. Maybe this will be for another episode. You are obviously a diabetes educator, but it'd be fun to have somebody else from a different pump company, because other pump companies will say, no, exactly as you're saying, like you're stacking insulin. We set it this way for a reason. It's not adjustable for a reason. Is this 2-hour duration a different setting from previous Medtronic pumps? Forgive me, I'm not as familiar with them.
No. That's a great question, Stacey. It's the same active insulin time. Honestly, that has been a part of the bolus calculator settings, the bolus wizard, and now the SmartGuard bolus feature. But even since the paradigm days, right, when the bolus calculator was first presented, we're now looking at decades ago with the active insulin time. So it's the same setting as we've had, but it's kind of viewed in a different way than it has been in the past, right? In the past, it was very traditional, like you're saying, and kind of how patients will think of it with, whenever I'm in conversation with them, they're like, how can this be? And the simple fact is, with setting the active insulin time as low as 2 hours, which is what we see the best control, the best time in range, and the lowest time below range, right? So the fewer lows is actually set at 2 hours. And what that does is it just is a tuning algorithm knob, and it says, hey, algorithm, I'm going to allow you to give, if you determine that it's necessary, me insulin, because you're looking at my rate of change. You're looking at how much insulin is on board. You know how many grams of carbohydrate that I've entered. It takes all of this information into account and decides if action should be taken. And what's lovely is the patient, the person with diabetes, that mom, dad, the family, they don't have to make any of those decisions. The system is doing it for them.
I should have probably started with this question, but what does the algorithm use as a starting base? We're used to traditional insulin pumps where you sit with your educator or your doctor and you say, here's my basal rate, here's my sensitivity factor or correction factor, or as we're talking about here, duration. There is a pump in front of the FDA right now that just uses body weight. What does the 780G use?
Yeah, that's a great question as well. Algorithm really starts with total daily dose of insulin, kind of as its starting point, right? The calculation. And that's why whenever you are new on the MiniMed 780G system, people have to stay in manual mode. So the kind of the non-auto basal and auto correction kind of piece of it. So they stay in manual mode for 2 24-hour days, right? So it's 2 days in manual mode, and then there's enough data as a starting point for the system to be able to say, okay, this is a safe basal amount for you to begin with. In addition, if there's sensor glucose tracings in that 48 hours of kind of that warm-up period to the SmartGuard feature, then those fasting sensor glucose levels, pump is looking to see like how much insulin do you require whenever you're not announcing meals, and so it sees, okay, your sensor glucose is in a fasting state. Now, how much auto basal is being delivered? And that is kind of the two main pieces of information of how the system decides how much auto basal to begin with and to deliver.
Got it. Can the user switch back to manual mode?
Yes, they can at any time. They can stop the SmartGuard feature. We know that the data is so overwhelmingly heavy. It weighs heavy on the SmartGuard side. So we definitely see a major difference in time and range being improved whenever people are in the SmartGuard feature versus in manual mode.
Right.
They're always encouraged to stay in.
Got it. But the system doesn't and I hesitate to say it this way, but you'll know exactly what I mean. The system isn't kicking people out as much as one of the very early automated systems from Medtronic, right? That was a big complaint with the 670 was, I got kicked out of auto mode.
That was a complaint. And we know that whenever the MiniMed 670G system, the first hybrid closed loop system of its time, was a pretty conservative algorithm, right? Because it was first of its kind, Medtronic really had to build in a number of safety precautions. Sure. And in many cases, it led to those unwanted alerts and alarms and interactions with the pump to keep the system kind of in that auto mode, SmartGuard auto mode feature. And so with this, the exits on MiniMed 780G system, I mean, they're just not happening, right? And again, the number one of two goals of this system was to reduce the daily interactions with the system.
Sure.
We can't have beeps and alerts and alarms and, hey, you have to enter a BG all the time in order to stay in to the automation mode. This is a big difference that people, especially those that have been on previous hybrid closed loop systems of all kinds, they're like, this is really a pretty big change, right? Exits at night, exits in the daytime, alerts at night. those are some of the things that are really different from a user lens. Whenever I hear anyone ask my husband, like, what's kind of from your standpoint of view, what's the biggest change with you seeing your wife wear the MiniMed 780G system for a while? And he just says, look, it just doesn't wake us up at night. And he just seems to be a little bit more pleased. A lot of surveys that have been conducted all throughout, the countries where people are using and wearing MiniMed 780G system, it's like 94, 95% of people are saying that they're satisfied with the impact on their quality of life. They're happier with the quality sleep. That's one that's pretty highly ranked and desired by many. So for us to get a good night rest and to feel confident to go to bed, lay our head down, not have lows or highs, not have alerts and alarms, that's the system that we need. And that's what people are enjoying.
One more question about manual mode. A listener had asked me, is manual mode usable during the auto mode? In other words, if somebody really feels like they need to do an additional bolus, can they do it?
It can be done, but I would kind of ask, why do they feel like it needs to be done, right? Mm-hmm. Why would you need to go out to manual mode if you need to give an additional bolus? So carbs can be entered at any time that those are consumed, right? We definitely want to announce our meals. And at any time in the SmartGuard feature, a patient can always look to see if what we kind of say a user-initiated correction dose is needed. So I don't ever want people to feel like once I'm in the SmartGuard feature, I can't take action if I see glucose where I don't want it to be, or if I've eaten something that I didn't tell it, go ahead and deliver a bolus. At least check to see if a bolus should be given. And maybe some of the feedback that patients had on MiniMed 670G system, where they felt like they had to enter in perhaps kind of ghost carbs or fake carbs when they weren't actually eating them to kind of trick the algorithm to giving more insulin. I think you'll find with now the controls that we have able to control on this system, like that active insulin time and the auto basal, I don't see that people at all are having to, what we say, automate the automation, right?
Well, let me ask you a follow-up on that, because I don't know anybody who uses an AID system who just puts in meal boluses and says, great, I'm always in the range I want to be. Are you saying that's what's happening with the 780?
Well, I'm saying that anytime that you eat in any of the AID systems, right, you can enter those grams of carbohydrate. But because MiniMed 780G system gives the auto correction doses starting at anytime glucose is over 120, if the auto basal can't handle that glucose response, then they're going to get it. So because you intervene, the system intervenes early and it intervenes often, there's less of a need to take matters in your own hands, right? So it's a different mindset. Really is.
Yeah, no, it sounds great. We'll see. When you said meal announcements, to be clear, you're talking about carb counting and putting in the numbers of carb you're eating. You're not just saying I am eating.
You're saying yes. So you're entering grams of carbohydrate. Thanks for clarifying.
Got it. No, I'm just I know it's coming. It's amazing to see how these things are changing. I just want to be clear as we go along.
Yeah, well, that's kind of a segue, Stacey, to a lot of the different thoughts on do people have to, now with auto corrections, do people have to be so precise on the grams of carbohydrate that they're entering into those systems?
Okay, well, let me give let's segue into that. Let me give you the best case use that I can make in my house for something like this. I have an 18-year-old. He's a great kid. He's very responsible with diabetes. He is terrible about bolusing before he eats. It's just not happening. And so we have a lot of, excursions that perhaps don't necessarily need to be happening. I would be thrilled at a more aggressive post-meal bolus system. So talk me through what happens. 2 scenarios for you. Somebody has an 80, I'll just throw 85 carbs out there because this happened recently. So somebody has an 85 carb dinner. They bolus 5 minutes after they finish it. Or somebody has an 85 carb dinner and completely forgets to bolus. How does the system handle those things?
Oh, yeah. Well, I'd love to show you my report. Because not only does it happen with an 18-year-old, it happens with me more than I would like.
Oh, my goodness.
You know, I've type 1 for 33 years. How am I forgetting to push the button?
I love it. You're
right?
human. You're human.
Yes, I'm totally human. So the 85-gram carb dinner, and they bolus 5 minutes later, right? We know that if you are not giving insulin before the meal, right, you're going to have food most likely showing up to the party before the insulin arrives, right? So you're going to have food there. Glucose is going to rise because of the food digestion, and then here comes insulin. In that case, we would say, look, if it's been, if you're really bolusing after the meal, you probably are going to need to reduce your meal bolus. And we have some exact parameters for healthcare providers to kind of discuss with their patients. But, on average, it's like, look, probably just dose for, maybe that's half in your case, maybe it's not. Because as you know, as that sensor glucose starts to rise, the autobasal starts to increase. It gets to the maximum, let's say, and then here comes the autocorrection. And then you've got insulin, from the bolus still showing up to the party at that point. So what's so great about this system is it knows, like, okay, autobasal's increasing. Then there's some, potential autocorrections. As soon as the bolus is given, the system goes, okay, let's back off, right? Let's see what's going to happen with this system before we really just push the pedal to the metal and start giving more correction, right? So everything is done with the total safety in mind, right? Which is something that's so great. Now, for the 85 grams of carbohydrate and they don't bolus at all, well, then that's really where the autocorrections and the autobasal can shine. That's really where you're going to see sensor glucose is rising. And am I going to say they're never going to go high with an 85-gram carb meal? I would say that would be, really unlikely. Depending on what the nutrients are in that food, I would think it was going to be unlikely. And so glucose is going to rise. The system is going to handle it as well as it can. But what I can see time and time again with when meals are skipped, that patients don't go as high and they don't stay as high as long. We have a study that actually supports that patients who did zero bolusing for a period of time. So this is every single meal for this length of time. And I'd have to look at the report to know exactly the days, but their time in range was just right under that 70% time in range. Yes. And so that's not at all what we are recommending, because we know that if you bolus and you're using the recommended settings, it doesn't matter if you're an 8-year-old or if you are a 18-year-old or if you're a 58-year-old or if you're a 78-year-old. We know that for everyone, you can have an upwards time and range of 80% plus, right? So we know it's better, and we absolutely want to provide the charge that we should be announcing meals. But it's so nice whenever the occasional, I forgot to bolus,
sorry,
that happens.
The occasional.
It's got your back for some more than others. Right?
Excellent. I did get this question about the bolusing system. How much of a correction is given? Because on some of these other systems, it's a partial correction. I don't know if you can share that. It may be part of the algorithm that you can't share. And then also, how does the system differentiate, or does it, between a missed meal and a random high, a high that may come for another reason?
Yeah, those are good questions. Okay, so for repeat the first one if you don't mind.
Sure. How much of a correction is given? Like on the T-Slim, I think, I may not be correct here, but it's something like, once an hour it can give 60% of the programmed bolus. So is that something that the Medtronic keeps in mind? And again, it may be proprietary.
Well, I can tell you this. The difference with the MiniMed 780G system is it gives a full correction, if needed, every 5 minutes. And every correction bolus, right? Just like if you were giving a correction yourself with a pump, you're going to enter your glucose. The system does the same. It says, look, this is where the glucose is. This is where I want it to be. and it's targeting 120 whenever it's giving a correction dose of insulin, right? That's why after 120, it can start to deliver a correction dose. And it looks at the difference and it sees how much insulin is going to be needed. And then it also applies other metrics as well, like how much insulin is circulating in the body. And then it determines the safe amount that is going to be needed every 5 minutes.
Got it. Okay, great. And then the other question is about, does the system differentiate between, missing a meal or a high for another reason? And I could think of highs, in teenagers for, hormones or exercise, things like that. Does the system differentiate? And I guess the follow-up is, does it need to? Or is a high just a high?
Yeah, really a high is a high. And that's what's so great about the system. Anytime there is a rising rate of change and, parameters are met that the pump says, wait a second, this is a rising rate. Oftentimes it's a meal that's missed, right? To meet the parameters. When the system sees that this is met, what it does is it allows a correction dose to be delivered even a little bit more aggressively, right? So, it does have a meal detection module built in. It has meal detection technology built in, but it doesn't so much say, oh, this is your sensor glucose is rising now because of the meal, so I'm going to act this way, versus your sensor glucose is rising because you have hormones releasing in the middle of the night and you're sleeping, right?
Right.
Either way, this system is looking at the sensor glucose response, and if corrections need to be delivered in a more aggressive manner, or larger corrections need to be delivered, either way, then the system is able to do that.
We've mentioned several times that you live with type 1 diabetes. I mean, I know I can talk to you about the pump for probably another 2 hours, and I hope you'll come back on and we can talk more about it. But I want to ask you about your journey. You were diagnosed as a teenager. What did you use? What was the first diabetes technology? I assume it was a blood sugar meter. Coming right back to Heather in just a second. But first, Diabetes Connections is brought to you by Dexcom. And Benny has been using the Dexcom CGM for almost 10 years now. That first insertion was in 2013, just before he turned 9. I mean, it was great then. If you've done finger sticks for a while, you know how amazing it is to go from that to continuous glucose monitoring. But it is even better now. The Dexcom CGM systems just keep improving, continuing to get more and more accurate with no finger sticks or scanning required. The easy push-button insertion has made it easy for Benny to do it himself. He has done every one since we switched to the G6 in 2018, which was really great for his independence back then as a younger teen. Of course, we still love the alerts and alarms, and that we can set them how we want. If your glucose alerts and readings for the G6 do not match symptoms or expectations, use a blood glucose meter to make diabetes treatment decisions. To learn more, go to diabetes-connections.com and click on the Dexcom logo. Now back to Heather talking about what things were like when she was diagnosed at age 16.
Yeah, I was diagnosed in 1990, and of course I had a meter. The old Lansing device that I had was the one that you lay on the table, and it's spring-loaded, and it swung around like a hammerhead, and it would poke your finger, right? So that was my first one. And, I was just on conventional insulin therapy, right? At least had disposable syringes. I wasn't sharpening a needle or have a glass syringe or anything like that. And, for me, Stacey, my parents were so great. My dad worked internationally, and they were just constantly talking to people there's got to be something better, right? Because I was doing everything I could. I mean, I really tried hard, and I have for, 3 decades. Tried hard to really kind of manage things. And they said, there's got to be something better. And that was right at the end. It was actually before the end of the DCCT trial when my parents were told, hey, we've got to get her on something better. We're starting to notice that these multiple daily injections are going to be a lot better. So went and started multiple daily injections. And at that point, this was in 1992. At that point, the healthcare team said, you ought to consider a pump. You're young, your parents have insurance. You guys are certainly kind of wanting to have the best control. You should consider a pump. And Stacey, for gosh, for 7 years, the first 7 years after I was diagnosed, I did not want an insulin pump to save my life. I wouldn't even think about it until someone said, hey, I had gained some weight in college, as many females and males do. And I was trying to lose weight, exercising on the elliptical and or the treadmill, either one. And every time I would exercise, I would go low. And every time I would go low, I would have to have juice and some peanut butter crackers or whatever the case was. And I was having more calories than I had exercised off. You can see the counter of your calories that you're burning. And I'm like, this is ridiculous. I'm going to continue to go low and not be able to trim down my weight some. And I didn't have the right tools. And so that's the reason I started on a pump and then have been on a pump for the last, 27 years, maybe.
When you used to do a lot of patient training on insulin pumps, and I know you still do some now, even in your role here, what are their biggest concerns? There's a lot of mechanical learning if you've never used an insulin pump before, but there's also, as you mentioned, there's a reluctance sometimes. Can you share a little bit about what patients tell you?
I think the unknown is the biggest thing for patients, right? They don't know if it's surgical. They don't know if it's how this goes in, how you disconnect, how you're going to live the 5 S's, as I call it. How do you sleep? How do you shower? How do you swim? How do you go, with exercise and do sports? What happens with intimacy and things like that? Those are unknowns. If you haven't met with an educator, if you haven't had a friend or even a healthcare provider that's kind of talked you through that. So I think once people understand how insulin pumps and continuous glucose sensors kind of work inside of our life and really how easy they are, the trainings are so much more simplified today because the therapy is so much easier, right? And so I think once they start to put the pieces together, like the technology is working in the background, I don't have to work as hard. Here's the 2 or 3 things that I have to do: change my infusion set once a week, change the sensor once a week, and then I have to enter some grams of carbohydrate, however those grams of carbohydrate are calculated. Then they start to understand this is not as big of a deal.
All right, I have to go back. You said the 5 S's, and then I kind of heard you editing as you went. You can say sex on this podcast, but what were the other ones? You had sleep, swim.
So sleep, shower, swim, sporting, and sex.
That's great. I love that list. That's a great list. All right, before I let you go, I can't let you leave without talking about Purple Hearts, this Netflix movie that you were a consultant on, right? Tell me a little bit about what happened there. This is a character that has type 1, and she marries a Marine to get benefits, health benefits, and it's a very romantic story. How did you come to be a consultant on that, and what was it like?
Well, what was so interesting about this? What a one-in-a-life chance for me. It was really great. The director or producer, I think it was the director, she had reached out to Medtronic specifically because she was, obviously going to be doing this movie. And her team had reached out to Medtronic, and she really wanted to, use product in the movie, but I guess her colleagues and friends and others that she had talked to, whenever she mentioned that this character was going to have type 1 diabetes, they were all like, yeah, well, we've worn this Medtronic pump for, years and years. And so that's why she reached out, right? So reached out to our communications team and our marketing team, and those teams were so great to say, hey, look, they're going to be using a pump and sensor on the set. They might need to have some help just making sure that everything is used correctly. And, I always, in films, in movies, etc., whenever I see things being used in an incorrect way. So, anyway, I was able to go out on the set, and then, one thing just kind of led to another, and they were like, well, we're going to need someone to train. Sophia Carson is the actress. What an amazing thing to be able to meet her and all the other just amazing talent on that set. And they were like, why don't you, you do this, so why don't you just do this in the movie? And I was so happy that tiny little piece was not cut. It was such an important thing for my friends and family to be able to see. So, and it really does kind of make people with type 1, I've heard over and over, it was so kind of cool for the film to kind of walk through people without type 1 diabetes, like there's a training, like we have to understand how to use this equipment. And it's kind of the big day whenever you go on an insulin pump. The coolest thing about the scene that I was in with Sophia Carson, whenever we finished the scene and she got on the system and we had everything moving and working and it was there, she was like, Heather, this is amazing that people go through this. And then she was like, I'm just going to give you a hug. Like, this is like, I feel empowered having this system on me whenever I'm playing a character that has type 1 diabetes. So it was very organic and natural, and that wasn't anywhere in the script, So it was just a true testament to how powerful technology is in people with diabetes lives.
Is there going to be a second one?
I have pushed, I have said, I hope that there is. Everybody wants to know what happened to those two characters after this. I don't know about it, but I would love to see a second movie as well.
That'd be great. Well, we will leave it there. Thank you so much for sharing so much of your time with me. I would love to have you back on to talk more about this system. We still have a lot of questions, I'm sure. We just scratched the surface, but I really appreciate your time. Thanks so much for sharing so much information.
Thank you, Stacey. Have a great day.
You're listening to Diabetes Connections with Stacey Sims.
Lots more information at diabetes-connections.com. I know I didn't get to all of your questions. I will definitely talk to the folks from Medtronic again. I thought Heather was really terrific in how she laid everything out. I loved her 5 S's. But you should also know that the 780G, she may have mentioned this, it's currently approved for users 7 years old and above with type 1. They have started taking pre-orders that happened in the middle of May, and they will be shipping later this summer throughout the U.S. If you have a 770G, you will be eligible for a free upgrade through remote software. If you want to be notified more, you can go, there's a link in the show notes, and get their upgrade notification newsletter. So just go to diabetes-connections.com, click on this episode's homepage. It'll give you all the information that you need. I'm taking a deep breath because, as I have been telling you, my May was bananas. It was wonderful. It was busy in all the best ways. But I went to Ireland at the beginning of the month. Then I went to New Orleans for my daughter's graduation. Then we had a giant family reunion at my house. So hopefully, as you're hearing this, nothing that busy has popped up for the month of June. What I do have on the calendar is the ADA Scientific Sessions Conference toward the end of this month. I have never been to this. I've always tried to make it, but it's never worked out. So I have a media pass. I have my microphones packed. Well, not yet, really. But I'm going to be going and talking to all of these companies. I'll be putting stuff in the Facebook group. So please join Diabetes Connections, the group, or sign up for our newsletter. And you can do that at diabetes-connections.com, because I'm going to be asking what you want to hear. Who do you want me to talk to? What questions do you want me to ask? I'm going to try to do a whole bunch of interviews while I'm there and set up a whole bunch more. You can always email me, Stacey, at diabetes-connections.com. I'm super excited about going to this event and really hoping to bring your questions to more of these folks. As I mentioned at the beginning of the show, I am scheduled to talk to Beta Bionics about the iLet. So that should be next week's episode. And of course, we have In the News this Friday to fill you in if there are any more FDA approvals. Hey, there's more stuff in front of them. This has been a really interesting year so far, and we're not halfway through. Thank you to my editor, John Buchanan from Audio Editing Solutions. Thank you so much for listening. I'm Stacey Sims. I'll see you back here soon. Until then, be kind to yourself.
Diabetes Connections is a production of Stacey Sims Media. All rights reserved, all wrongs avenged.